Welcome back to the Weekly Neurology Deep Dive. In this deep dive, we're going to be examining a systematic review and meta-analysis looking at the use of pyridostigmine for orthostatic hypotension. And just a quick note, as always, this deep dive is for educational purposes only, and we don't have any commercial goals here. What we're going to give you is essentially a summary of the research that we looked at, but if you want a complete understanding, you'll have to read the full paper. Now, just to level set really quickly, orthostatic hypotension, which we're going to call OH from now on, is defined as a drop in systolic blood pressure of at least 20 millimeters of mercury, or a drop in diastolic blood pressure of at least 10 millimeters of mercury within 3 minutes of standing.
And OH can actually be caused by a number of different things, neurogenic causes like neurodegenerative diseases, peripheral neuropathy, or even non-neurogenic causes such as cardiovascular disease, medication use, or even volume depletion. And patients with OH actually face an increased risk of syncope, falls, functional impairment. There's a risk of hospitalizations and also reduced quality of life. If you look at elderly individuals with OHs, they're also at a higher risk of cognitive decline, dementia, and vascular-related death.
Now, I know that currently we have a couple of different treatments available, like midodrine and fludrocortisone. And while they're definitely helpful for OH, they can make supine hypertension worse. And obviously, that's something we want to try to avoid as much as possible. And that's kind of where pyridostigmine comes in. There's been some thought that it might be a good alternative for improving OH without that nasty side effect. So, in this deep dive, we're going to explore the findings of a systematic review and meta analysis of randomized controlled trials that looked at pyridostigmine for all cause OH. And we really want to focus in on the data that's going to be most relevant to neurologists like yourself in your day to day clinical practice.
Well, first off, let's discuss what this review actually looked at. The systematic review used data from 6 randomized controlled trials, and these trials were identified through searches of PubMed, Embase, Cochrane, and Scopius. And these databases were searched up to June 4th, 2024. And what they were looking at was the change in systolic and diastolic blood pressure on standing. That was the primary outcome. The secondary outcomes included postural symptoms, side effects, and changes in supine blood pressure. And the quality of the included studies was assessed using the Cochrane risk of bias tool.
So let's just jump right into it. What did this review find about the efficacy of pyridostigmine when it was used all by itself as a single therapy?
Well, there was one study by Singer and his colleagues back in 2006 that found a pretty significant difference in blood pressure fall. They saw a drop of 27.6 millimeters of mercury with 60 milligrams of pyridostigmine, compared to a 34 millimeter mercury drop with a placebo. And that difference was statistically significant with a p-value of 0.04. And then another study, this one was by Bian and colleagues in 2017, reported a significant decrease in both orthostatic, systolic, and diastolic blood pressure drops. And this was at 3 months with pyridostigmine monotherapy at a dose of 30 milligrams twice daily.
So it sounds like pyridostigmine as a monotherapy had some positive results in those studies, but I imagine the findings weren't universally positive across the board, right?
Right, you're absolutely correct. We have to look at the complete picture here. There were 2 trials that did not have such positive results. One was by Shibao and colleagues in 2010, and the other was by Okamoto and colleagues in 2019. And they both found that a single 60 milligram dose of pyridostigmine did not have a significant effect on OH compared to placebo. And one thing that the researchers noted was that these patients actually had more severe autonomic impairment at baseline. Their baseline orthostatic systolic blood pressure reductions were negative 60 millimeters of mercury and negative 62 millimeters of mercury, respectively. And that was compared to 44 millimeters of mercury in that Singer study that we talked about earlier.
So it seems like if a patient comes in and they've got a really significant drop in their blood pressure when they stand up, pyridostigmine alone might not be as effective a treatment.
Exactly. And the authors of the review actually proposed the way pyridostigmine works, it enhances the signaling of preganglionic fibers. And this means that it may be less effective in cases where there is significant damage to the postganglionic afferent fibers. So if you're dealing with a patient who has severe autonomic failure, you might not see as much of a benefit from pyridostigmine by itself. And when you combine the data from 4 of these studies in a meta-analysis, they found a lower systolic orthostatic drop with a mean difference of negative 2.07 millimeters of mercury. But the 95% confidence interval ranged from negative 4.20 to 0.06. And for diastolic orthostatic drop, the mean difference was negative 4.58 millimeters of mercury, with a confidence interval of negative 11.45 to 2.29. So neither of those differences were statistically significant.
So it sounds like the evidence for pyridostigmine alone is a little bit mixed. What about using pyridostigmine alongside other treatments? Did the review shed any light on that?
Yes, definitely. And this is actually where the data starts to get a bit more interesting. One study, the one we mentioned earlier by Okamoto and colleagues from 2019, they found that when you combine 60 milligrams of pyridostigmine with 18 milligrams of atomoxetine, it actually created something called a synergistic pressor effect. Basically, the two medications work together to significantly improve standing systolic and diastolic blood pressure in patients who had severe autonomic failure. And the p-value for symptom improvement was 0.023. So if you have a patient with severe autonomic dysfunction and pyridostigmine alone isn't doing the trick, combining it with atomoxetine might be a strategy worth exploring.
That's really helpful to know. Now, what about using pyridostigmine with midodrine? Because as we know, midodrine is already a pretty common treatment for OH. So did they look into that combination at all?
They did. The meta-analysis actually included two studies that specifically looked at the combination of pyridostigmine and midodrine. And what they found was that this combination resulted in a statistically significant improvement in systolic orthostatic drop compared to a placebo. The mean difference was negative 6.74 millimeters of mercury with a confidence interval of modicip of 13.15 to narrow 0.33. And if you go back to that 2006 study by Singer and his colleagues, they also reported a significant reduction in the drop in standing diastolic blood pressure when they used 60 milligrams of pyridostigmine with 5 milligrams of midodrine. In the combination group, the drop was only 27.2 millimeters of mercury versus 34 millimeters of mercury in the placebo group. And that difference was statistically significant with a p-value of 0.002. So it really does seem like adding pyridostigmine to midodrine could lead to a better blood pressure response in at least some patients.
So you're saying that for patients who aren't getting the results they need from midodrine alone, adding pyridostigmine might be a good option. Now, I'm curious, were there any studies that directly compared pyridostigmine to midodrine head-to-head?
There were a couple. The study by Bion and colleagues in 2017, they actually look at this directly. They found that pyridostigmine at a dose of 30 milligrams twice a day was pretty effective at reducing OH symptoms, and it was comparable to midodrine at a dose of 2.5 milligrams twice a day. The patients who took pyridostigmine saw a mean decrease in orthostatic systolic blood pressure of 7 millimeters of mercury and a decrease in diastolic blood pressure of 4 millimeters of mercury. And then there was another study. This one was by Limothana and Charing Saris in 2022, and they looked specifically at patients with Parkinson's disease. It was a smaller study, only 13 participants, but they found that pyridostigmine at a dose of 30 milligrams twice a day was actually better than midodrine at 2.5 milligrams twice a day when it came to reducing orthostatic systolic blood pressure. The reduction with pyridostigmine was negative 0.43 millimeters of mercury compared to negative 19 millimeters of mercury with midodrine. And that difference was statistically significant with a p-value of 0.022.
That's interesting, although, of course, with such a small sample size, we have to be cautious about interpreting those results from the Parkinson's study. Now, sticking with Parkinson's disease for a moment, did the review give us any broader insights into using pyridostigmine for OH in this specific patient population?
Yes, they did. There was a non-inferiority trial by Schregelman and colleagues back in 2017 that compared pyridostigmine bromide titrated up to 3 times 60 milligrams per day to fludrocortisone titrated up to 0.2 milligrams per day. And unfortunately, they found that pyridostigmine was actually inferior to fludrocortisone for managing OH in Parkinson's patients. This was based on the diastolic blood pressure drop that they measured during something called the Shalong maneuver, which is a standardized test for assessing blood pressure changes upon standing. So if you're dealing with a Parkinson's patient who has OH, fludrocortisone might be a more effective first-line treatment based on the findings of this trial.
That's really useful to keep in mind. Now, one thing that struck me as I was looking through the review was that the findings on symptom improvement seemed a little bit all over the place. Some studies showed improvements and others didn't. So what's the overall takeaway? Does pyridostigmine actually make a difference in how patients feel when they have OH?
It's a good question. And you're right, the results were a bit mixed. For example, the 2006 study by Singer and colleagues, they found that there was a significant association between an increase in systolic blood pressure and improvements in OH symptoms. Patients felt better when their blood pressure was better controlled. The p-value for that association was less than 0.001. But then you have the 2010 trial by Shibao and colleagues, where they found that a single 60 milligram dose of pyridostigmine didn't really have any effect on presyncopal symptoms, those feelings you get right before you faint. In that study, it was actually yohimbine that showed improvement in those symptoms. Byens and colleagues in their 2017 study did see some improvements in orthostatic symptom scores and disability scores after 3 months of treatment. And this was true for the patients in the pyridostigmine monotherapy group, the midodrine monotherapy group, and the combination therapy group. And then there was the study by Okamoto and colleagues in 2019 where they found that only the combination therapy of atomoxetine and pyridostigmine led to an improvement in orthostatic symptoms. The p-value for that was 0.023. So it's a bit of a mixed bag.
It seems like pyridostigmine alone might have some benefits for some patients in terms of symptoms, but the combination with atomoxetine seems particularly promising, especially for those dealing with severe autonomic failure.
One of the things that's been highlighted about pyridostigmine is that it might be less likely to worsen supine hypertension, which is a big plus. So, what did the review have to say about this?
Well, out of the 6 studies included in the review, 4 of them actually found no link between taking pyridostigmine and any changes in supine blood pressure, which is encouraging. But there was one study, the 2017 one by Bien and colleagues, that did find something interesting, and this was the study with the longest follow-up period. They followed their patients for 3 months. And they noticed that in both the pyridostigmine-only group and the pyridostigmine-midodrine combination group, the patient's average supine systolic blood pressure went up. In the pyridostigmine-only group, the average supine systolic blood pressure actually increased from 124.5 plus or minus 18.5 to 135.1 plus or minus 22.5 millimeters of mercury at the 3-month mark. So even though we tend to think of pyridostigmine as being less likely to make supine hypertension worse, it's still really important to keep an eye on those supine blood pressure readings over time, just to be safe.
That's a good point. Always good to err on the side of caution. Now, how about side effects? Were there any notable adverse events reported in these studies?
For the most part, the side effects were pretty minimal and didn't last very long. This was consistent across the studies. Some patients did experience anticholinergic side effects, but they were generally mild enough that patients didn't need to stop taking the medication. If we look at the 2017 study by Bon and colleagues, 25% of the patients in the pyridostigmine-only group reported some symptoms, things like dizziness, which actually got worse for 5 patients, headache, which affected 2 patients. 2 patients had some gastrointestinal symptoms, and then there was 1 patient who developed limb tremors. But there was also a follow-up survey done on the patients from that 2006 study by Singer and colleagues, and this follow-up was conducted by Sandroni and colleagues in 2005. And what they found was that 85% of the patients who were still taking pyridostigmine after an average of 19.5 months reported being extremely satisfied with the treatment. So that suggests that pyridostigmine is pretty well tolerated in the long term for a lot of people. The main reasons why patients decided to discontinue treatment were side effects, lack of improvement in their symptoms, and then just the hassle of having to remember to take the medication regularly.
It's always good to hear about treatments that patients are happy with in the long run. But of course, we always have to be mindful of the limitations of any research study. So, in terms of methodology, what were some of the key things that you think neurologists should keep in mind when they're interpreting the findings of this review?
Well, the first thing to remember is that out of the 6 studies included in this review, only 2 of them were double-blind randomized controlled trials. And as you know, that's the gold standard when it comes to minimizing bias and getting reliable results. And then there was that one study we mentioned that used a non-inferiority design where they compared pyridostigmine to fludrocortisone. But the thing is, the evidence supporting fludrocortisone's efficacy in treating OH isn't rock solid. It's not a slam dunk that it's the best treatment out there. And then you have the fact that a good chunk of the studies use crossover designs. And those can be tricky to interpret because you have to worry about potential carryover effects from one treatment to the next. And the washout periods, the time between treatments, they weren't always consistent or clearly reported, which makes things even more complicated. And on top of that, most of the studies really focused on those short-term changes in blood pressure or symptom scores. They didn't collect a whole lot of data on long-term outcomes like falls or hospitalizations, which are things we obviously care about a lot.
And we can't ignore the fact that the sample sizes were relatively small in these studies. The biggest one only had 87 participants. And some of the studies included patients with all sorts of different causes and severities of OH. It was a pretty mixed bag. So all of this is to say that while this review definitely gives us some valuable insights into how pyridostigmine might be useful for OH, we still need more high-quality research to really nail down the best ways to use it.
Absolutely. Always good to keep that critical lens on when we're looking at research findings. Well, I think this has been a really helpful deep dive into pyridostigmine for orthostatic hypotension. We've seen that it may have some benefits, especially when it's used in combination with other treatments, and it might be a particularly good option for certain groups of patients. But we also have to keep in mind those limitations of the data that we've discussed. And it's crucial to monitor that supine blood pressure even when patients are on pyridostigmine. And as always, we encourage you to read the full research paper if you want to get the complete picture. So, as you go about your practice, keep this information in mind and think about which of your patients with orthostatic hypotension might actually benefit from a trial of pyridostigmine either by itself or in combination with another therapy. I think that's a really important question for all of us to consider as we continue to work on managing this challenging condition.